Thanks for having me and thanks for attending. I hope everybody can hear me okay. So I'm a general ophthalmologist in a practice medical retina in the Tampa Bay area in Tampa, Florida. And last year I was looking for a laser, and I wanted to tell you what my thought process was going through, what made this, the laser, my choice. So that's the politically correct title, sorry, for our talk, but I think it's more interesting, I'll just come right out and say it. Can you really laser the center of the fovea, and why would you want to do that? After hearing what all these different lasers do, I started to become frustrated with, for chronic swelling right in the center of the fovea, what are things that you can actually do to treat? And you really, lasering the center of the fovea sounds like a horrible idea, but I think you'll see at the end of this talk today, actually it might be the way to go, as long as you can safely do it. And this is the only laser that can do that. I also want to talk about how my drug bills for Avastin, Eylea, Lucentis, all the expensive drugs went down from $40,000 a month to $13,000 a month after I got this laser. So it paid for itself in a very short order. Also doing injections over and over again, you can't help but know that after a while of doing it, atrophy is an issue. So if you lose vision from swelling or you lose it from atrophy, you still lost vision, slowed reading speed. So we have to have another tool in order to fight chronic swelling in the center of the fovea. Because as good as the injections are, there are limits. And then I started to wonder, well, if you're lasering and you're not using thermal energy to create a burn, what are you doing, and how does that work? I also thought, how can I free up more time in my clinic by not doing as many injections over and over and over again? And in Florida and other places, a lot of times you're limited on what you can bill with the injection. You don't often get to do an exam or anything else. And there are many insurance companies, not Medicare, but as some of the privatization of Medicare has occurred, you'll see that they're actually paying less for the drug than what the drug costs you. So just for those who don't know, what is micropulse technology? Instead of pushing your foot on the laser and you create a burn with just solid energy, the micropulse is turning the laser off for short periods of time and letting the thermal effect of the burn or the heat that you've applied not create a burn. And if you can get down to where you have a 5% duty cycle, where it's on only 5% of the time, and then it's the tissue is cooling the other 95% of the time, you can create a spot that you can't see, and that fluoresceins can't pick up, and that autofluorescence can't pick up, and then OCT can't pick up. So you have to think this has to work in some different way because you're not creating a burn. You can't tell that anything's been done except that the patient gets better, right? So you're not doing nothing, you're doing something, but you're doing it in a different way than what we're used to thinking about with conventional lasers. So when I was shopping for a laser, I thought, well, why buy this laser? Every other laser does the same thing. And so I put this in yellow because I ended up getting the yellow version of the laser, the 577. But can I do something that I can't do otherwise with other lasers? Can I expand the things that I can treat in my office? Can I do better for patients? Can I do better for my practice? And I think you'll see that it's a winner for everybody. There's not many things in medicine where everybody wins. This is one of those situations. So again, we were talking about what are we doing with micropulse. You know, one of my techs asked me, if you're not burning, then what are you doing? Or is this just placebo? And no, it's not. You'll see 100 other talks today and on the Iridex website where you see the swelling in the center of the fovea or away from the center of the fovea. Anywhere in the retina goes away where you treat it. So you're doing something, but we don't exactly know how that works. So when I was a resident, Don Gast had retired from University of Miami and came to Vanderbilt for a while. And it said something to me that I always remember is you can almost predict the future by the way the RPE looks. And it's really true. You can kind of tell what's going to happen down the road by the way the macula looks and the RPE response. So I think it works by somehow stimulating that part of the body to become stronger and not leak fluid as much. I'll show you some studies that kind of support that. And where does this laser fit in? Turns out it expanded the number of diseases I could treat. So this becomes a big deal. So again, micropulse, instead of a continuous wave, it applies a sub-burn kind of level of energy that other people have shown that creates a up-regulation of certain kind of growth factors that are conducive to good retinal health. So how all those things work is beyond me, but it's amazing that somebody has actually gone and measured all these things. And we have a biologically plausible reason for how micropulse works, why it makes the retina stronger and not leak so much fluid. These are on the Iridex website. So the nice thing that you would think that, I've had other people ask me, well, if you turn down the power low enough in your continuous wave machine, aren't you creating a subthreshold burn? And you are, but you can still see those with autofluorescence and with fluorescein angiograms and other on biopsies. But what you definitely get with that is microperimetry. With microperimetry, you'll see water spots in their vision. And the patients, your diabetics who've been lasered to death will tell you that there's a place where things are grayer. It may not be an absolute scotoma, but it's grayer. And I have a vested interest in this because I've been diabetic since I started medical school. I've been a type 1 diabetic. If I haven't needed laser, I hope I never do, but if I ever did, not creating a burn close to my fovea would be a very, very good thing in my opinion. So, and you're not, again, we talked about you're not doing nothing. It's not a placebo effect because people are getting better. I think you're going to see in some of the case studies I show, I've had some people get off injections now for more than a year and a half, or a year and 2 months. So again, this is just from their glaucoma side. I do use a machine for MLTs, but you're not creating a burn. You really can't tell anything's happened with the eye. So it perhaps promotes a more normally functioning RPE. So I've treated a variety of conditions well. Your website, the Iridex website, has a lot of good ones on there, but it's missing some. Diabetic macular edema from vein occlusion, central serous, all stuff that you can treat, but can you treat it right in the center? Can you get rid of that last little bit of fluid? And I say with the Iridex on micropulse, the yellow one, you definitely can do it. The pseudophakic, somebody who's had surgical misadventures had a chronic pseudophakic macular edema. Eventually they get sick of those shots, and they're probably sick of seeing you too. If you can get them free of shots with their final good vision, I think that's going to be a very good thing. And I think the holy grail here is, and I'm going to talk about this from my small studies that we've done about the chronic edema from wet macular degeneration. Is there a way that you can get away from using injections over and over and over again with all the atrophy that can cause? So, so you can use it in traditional mode, but we're going to show you a bunch of reasons why you don't need to do that. So my first case is a 70-year-old with non-insulin dependent diabetes who's had previous focals for CSME, or macular edema. She got on the wagon. I'm pretty hard on my diabetics about going to diabetic education, exercising, but she fell off the wagon and she's been at 8 to 9 in her hemoglobin A1Cs for a year and a half. She works as a legal secretary and her computer vision's worse and her reading speed's slowing, but she still has 20/25 vision. She's had crystal lens surgery with me, but we're going to be in trouble. She's doing everything right, but you can see the edema starting to come in the center of the vision like this. And she's been treated far away from the fovea, but not around the fovea for obvious reasons with traditional laser. So I use these settings recommended by Iridex and the other doctors using it, Dr. Mansour's especially. So I used a transfoveal yellow micropulse technique in February of this year. You first create a test spot with regular laser on the continuous wave. You turn it down to about to see nothing, and then you turn it down one more, multiply that by 4, double the spot size and double the time, and you're really introducing a very, very low level of energy, especially at 5% duty cycle now. But the trick with this is you've got to be confluent. You've got to paint everything with the laser. So I had done this a couple of times on patients with worse vision, and you see that they don't get worse, they actually got better. So I felt pretty comfortable doing this 20/25 patient with macular edema. And so we do a confluent pattern throughout this macula with 120 spots. And you can see you have a little less edema approaching the fovea. This is just done 2 days ago. She still has some, but it's a lot less. She's 20/20 now, doesn't have as much slowed reading speed. So I'm not going to show the absolute perfect ones during my talk, but you'll see there's got plenty of examples where it goes away completely. But she's not worse, and here it shows you can laser the center of the fovea. By the way, her hemoglobin A1C still stinks, so she's no reason to get better other than the laser. So another lady had a crystal lens cataract surgery with me, 70-year-old with a CSR that used to recur, central serous that would recur, decides to come back a year after surgery. She still smokes. She's tried all the holistic things like taking lutein, which there's some evidence that it helps. And she's got a vision of 20/70. She's got this pigment epithelial detachment. Go right through the center of the fovea with the laser, same technique, and that's what she has. 6 weeks later, I think this is a little unusual. She's still getting better. We've talked to her since. The nice thing with it, the first do no harm in fovea-friendly treatment is that it works, but it takes a while to work. It takes about 4 months to really kick in. So it's nice. I tell my patients that they need to be patient. This is trying to do something to affect a longer-term cure or a longer-term independence from injections. So I didn't do it in her case, but there are people who you'll give some like Avastin or whatever, just to make them feel better and see better right now until the laser can kick in, and then you've won. So Transfoveal Micropulse, like we said, she's 20/40 now, only 6 weeks out. Now she's 9 weeks out, and she says she's getting better every week. But again, maximally, it's 4 months before you see all the effect. So Micropulse works for one-time therapy, but does it work for more chronic diseases like the vein occlusion that you've had to inject over and over again, or have been lasered, but you can't get too close to the fovea? So here's, this is one that's not a vein occlusion, but she's had a surgical misadventure somewhere else. She's a 72-year-old non-smoker with chronic CME after complicated cataract surgery. Great physical condition, eats well. She has CME that recurs, but she's dependent on steroids, and she's tried everything, topical, implants inside the eye, and Avastin for years, and non-steroidals are not that helpful, but she's can't really get her better than 20/70. She's initially response gets to 20/30, and as the drug wears off, she goes back to 20/70. So this doesn't show a lot of fluid, but you can see the fluid in the center of the fovea there, or just in the fovea. We'll laser right through it. And those are the settings. We do the test spots, and then we multiply the size of the spot by 2, the time by 2, and the power by 4, and then the duty cycle takes things down by a factor of 20. We stopped steroids and have given her no supplemental Avastin, no non-steroidals. She's 20/25, 5 months out on no medicine. So prior to this, she had 4 years of chronic misery coming back to the office to be treated. So this gives you one more tool to take away chronicity. And there she is after the focal. She's perfect. This is 4 months after the focal. So again, wait 4 months. So can you get away from repeat injections? You know, there's all these new studies that say, new pharma-funded studies that show that most don't keep up with the recommended protocols. No surprise, they're expensive. People get tired of doing it. As good as they are, after 2 or 3 years of getting shots every month or two, people start to poop out. They're also, so is there another way? Do we have to robo-inject everybody? I don't do that. I do treat and extend. But even after a while, you'll see the treat and extend starts to wear out. Cost for some people is an issue. There's really only Medicare that pays for some of the more expensive drugs, so you often don't have a chance to change medicines around. At least in Florida, the Medicare replacement plans don't pay for any. They're years behind Medicare in paying for drug treatment. Tachyphylaxis has been a big problem. After you do treat and extend, it starts to become less. The interval gets less and the results get less. And the biggest side effect is atrophy. So when do you stop? So atrophy, whether it's from geographic atrophy or repeat injections, is a very bad thing. Those are either microscotomas or absolute scotomas where that patient can't put things together and the vision will fall. That's all bad. So there we just said some of the things I just said, but you don't have to stop using anti-VEGF. I'm not telling anybody to go cold turkey, but you'll be surprised what you can get away from. We've been, before Micropulse, which we started in August of 2013, we were spending, and this was increasing every year, we were spending about $400,000, or it's $40,000 a month, $480,000 a year on intravitreal injections. That fell to about 13,000 4 months after we started. So it's pretty impressive. Once we saw that we weren't damaging the fovea, we were pretty aggressive about treating everyone. Most people wanted to stop using the injections. So some people, I would say maybe 50% still need an injection here or there, but most people have gone without an injection for a year or more. So Micropulse is just an option. Here's an AMD case, a 70-year-old white male who develops wet AMD 3 years after cataract surgery, despite being on all the ARED's recommended vitamins. The vision varies from 20/40 to 20/60 on a Q6-week Avastin regimen. That's about as far out as I could get it. But fluid was getting harder and harder to eliminate. They had a chronically boggy macula with chronically bad vision. So that's what he looked like. It's not terrible, but 20/60 to him looks terrible. And then the OC, well, so we do a transfoveal yellow micropulse laser in January at the 5% duty cycle. Iridex used to have on their website, I haven't seen some pathology studies of what 5% and then 10% looks like. And it looks like at 10% you can faintly see something happening. I was hoping to include that, but I didn't on these. But 9 months, it's been 9 months, he did 10 months since his laser, and we haven't had injections in 9 months. So that's pretty good, and his vision's 20/40. So I lasered the center of the fovea and no side effects, and he's better off. So this is a very different way to think about stuff, because usually we're taught not to, you got to respect the macula. We do respect the macula, but if you understand the science, this is not the same laser as everybody else's laser. This is a much, much, much higher safety factor and a much, much higher efficacy factor for treating the center of the fovea. That was, we gave him Avastin right before the micropulse, and you can kind of see that fibrotic SRNVM with some fluid in the intraretinal space. Not much, but starting to look a little bit better, more normal contour. He's not perfect, but he's 20/40, he's not 20/70, and he hasn't had an injection in a long, long time. So success in chronic disease, you may need more than one treatment, may just stabilize the OCT, you may not perfect it, but that doesn't happen with intravitreal injections either. You may reduce but not eliminate the anti-VEGF treatment, but I think you do spare them from atrophy. You can definitely hear people tell you that their reading speed is no longer on the decline. And you're in a financially situation for all concerned. Your patients aren't spending, 20% of an $1,800 copay is not an insignificant amount of money, it's 450 bucks. So every time they come to see you, there's not much of the US population who has an average disposable income of $136 a month who can do that over and over and over again. So I think they're better off. So here's one-eyed guy, 71-year-old, lost his left eye to wet AMD 10 years ago. He's only got one eye. I sent him to smoking cessation over the last 4 years. He's on Preservision. He takes lutein at a different time. He's taken fish oil. He's tried all the different things that reduce the rate of progression of disease, and he develops wet AMD in his right eye in 2010 and has 31 injections. And so this is, the intervals were becoming shorter after treat and extend. We got him out to 3 months, and then 10 weeks, and then 8 weeks, and then you can see him on the decline, and he sees things going the way of the other eye. We can see the atrophy, and his vision is, so vision is only 20/40, but he's 20 miserable. So again, great vision. One eye, somebody wants to laser the center of the fovea, see if we can save this guy's eye. So we do it in December. That's what he looks like. If you can see the atrophy actually starting to settle in, where it's lighter colored. And again, this is a really common clinical scenario. All of you probably have somebody where treat and extend is not working anymore, 2 or 3 years out. You're having to use a bunch of different things, and it's come up. Although it's controversial, if the patient's got high eye pressure, do you keep using Avastin? Have they had a stroke and their doctor and their family's heard about all these other medicines? Is there something else you can use? And it turns out the answer is yes. And a lot of things in cancer, politics, and war, and now macular disease, is that fighting a war is best done on 2 fronts. You're more likely to win if you're using more than one trick. So he has transfoveal micropulse at a 5% duty cycle. The fluid remains, but without dropping vision in May. So I had some experience with the 10% duty cycle and people who have vision like in the 20/40, 20/50 range. Now we're in September, he's 2025. So he's just had 10%. The books say I can't do that, but we've done it, and there's no intravitreal injections in 9 months. So you don't have to start the way I did, but you can definitely get closer and closer to the fovea and not harm your patients. And that's what he looks like today. Again, you have to be confluent. Iridex sells devices to help you be confluent if you don't want to paint it yourself. There's the Texcel that can do that for you. But that's how you get the biological response in all the tissue that you want. You want all this retina to become stronger, better, somehow, however it's doing it. I don't think you're not thermally doing it, but you're doing something to make it stronger. So you can, the take-home points is definitely you can treat the center of the fovea at a 5% duty cycle. You can even go up to 10% for refractory cases or if the vision's 20/50 or worse. It doesn't harm, it doesn't leave watermarks or microscotoma in the vision. It's easy to administer. And actually, you're better off financially. Insurances pay for focals. You're a pass-through for an expensive drug, for Eylea, those kind of drugs. It's like doing pain management at my surgery center. I was watching $200,000 just flow through me, and I never saw any bit of it. Here, at least, you can profit, and the patient's doing as well, doing better than with just medicines alone. Let's take a look. So that's it. It's not a one-trick pony. I highly recommend the IQ 577. I think there's probably good evidence you can probably do the same thing with the 532, but I can't speak to that. And it does, you need it because it can do what other lasers can't. You can't laser chronic CME, pseudophakic CME. You can't treat the center of the vision with any other product. So it safely treats the center of the fovea. So any questions I'll be happy to answer. Sorry.
Thank you very much. I can't clap because I have no hands. Thank you.
Thank you.
Are there any questions, any comments anybody would like to add? Well, Dr. Mahootchi will be here when we turn the microphone off, so if you would like to talk with him, I invite you to come on up and appreciate your attendance. Thank you.
All right. Thank you.
Thank you.
All right.